All right, this is the last segment that we have for our session today, and we will hear from Brittany Green and Grace Talbot-Schmidt during our Ask the Experts panel. Grace Talbot-Schmidt is a pediatric registered dietitian at Texas Children's Hospital. Her coverage areas include outpatient, complex care clinic, and the TCH MDA Care Center. She has experience in pediatric nutrition for the past 4 years, and she's a native of Baton Rouge. Grace has been a volunteer with the Louisiana MDA Summer Camp since 2011, so thank you very much for that. Brittany Green is a physical therapist at Texas Children's Hospital and the lead PT in the multidisciplinary MDA clinic. She has been a physical therapist for 6 years and has worked in the MDA clinic for 2 years. Her additional specialties include the Hammersmith, CHOP, Intend, and RULM trained, Schroth certified for treatment of scoliosis, secondary therapist for limb reconstruction clinic, and Teen WOW clinic for overweight adolescents. So Grace, I will turn it over to you and you can begin.
Okay, perfect. Can you hear me okay?
Yes, we can.
Okay. Well, thanks for having Brittany and I. We hope to share just a quick note about the importance of nutrition and PT in our neuromuscular population, and then of course we'll open for questions. So just to go over objectives for my part of the presentation today, we will talk about the components of a healthy diet, why they are important for our neuromuscular population. And of course, the focus of today's series is on pediatrics. However, a healthy diet is definitely applicable to the whole family. And so I hope some of the tips that I shared today are helpful for everyone. And then next, we'll talk about some of the common nutrition implications in neuromuscular diseases. So oftentimes problems with growth, GI concerns, constipation, and swallowing problems. And then lastly, we will talk about vitamins, what vitamins can be helpful in the neuromuscular population and when they might be necessary. And then just a general overview of nutrition. Probably the most common question I get asked by families is, does my child need to be on a certain diet? And the easy answer to that question is no. There's no research that supports one particular diet for any neuromuscular diagnosis. Every child truly is unique, and the same applies to their diets. However, as we know, there is research that shows that a healthy diet is important for overall health and well-being, and so it's also important for optimizing the health and functionality of our neuromuscular kiddos. And then, of course, just last to note, the role of the dietitian, I might be a little bit biased, but a dietitian can hold an important role in the healthcare team. Most dietitians have gone through 4+ years of schooling to obtain our certification. And so the way I approach my clinical practice is really listening to the parents' goals for their child, whatever their particular child's health needs are, and trying to match that with my clinical expertise. And then one last thing I did want to note, I didn't include on here, but about protein, a lot of parents wonder if their child needs extra protein in their diet, but that is not necessarily the case. Adequate protein is more so the goal and more than enough to meet their needs for their muscles and any treatment therapies that they might be on. And so the first note, what makes a healthy diet, my first point, I would like to make that food is fuel or energy for the body, and so all foods really can be part of a healthy diet. I do discourage, looking at foods as either good or bad. We will talk about a little bit later, there are some foods that we might want to limit more than others, but certainly they all can be a part of a healthy diet. And then you may be familiar with the My Plate picture on the slide, which is kind of the USDA's new food pyramid. I think it's a lot more helpful than the pyramid because it lays out what a healthy, balanced plate should look like. And as you can see, half of the plate is fruits, vegetables, and then a fourth protein and a fourth grain. And so then kind of going back and looking at the second bullet point on how to make that healthy plate. For carbs, we want to really focus on fruits and vegetables and really incorporating more whole grains in the diet, so whole wheat bread, brown rice. And then for our fats, in the diet, really focusing on unsaturated or heart healthy fats. And so those are going to be your fats that are liquid at room temperature. So cooking more with oils versus, solid fats such as butter, margarine. And then protein, definitely focusing more on lean meats. So, turkey, chicken, and then also those plant sources that we might not, think of often as sources of protein. So beans, legumes, and then of course, ensuring that kind of talking back on the protein, ensuring that we have a protein source at every meal will definitely help meet those adequate protein needs that your child needs. And then the last 2 points do kind of go together. Definitely the American diet can be pretty high in added sugar and high calorie beverages. And so, these can be a source of weight gain and other health problems. And so really in approaching, a healthier diet for families, a great first step is often, taking out those unhealthy beverages or really looking at better beverages, water and milk, even juice. I know sometimes there's a misconception with juice, but even juice can kind of be a very concentrated source of sugar and calories. And then, of course, limiting the amount of added sugar in the diet, which we can kind of look at on the next slide. There are some updates that were made to the nutrition facts label. One kind of exciting, if you look at the second arrow, there is a part on the label that now shows how much added sugar, so how much of those total sugars in the product are from added sugars like sweeteners and cane sugar. So definitely important to look at. And looking at this particular product, recommendations by the American Heart Association are 25, less than 25 grams a day, really less would be better from added sugar. And so this particular product, we're nearly halfway there. So really, being mindful and starting to look more at that label. And then kind of to jump back up to the top of the label, something, we might not always look at is looking at the particular serving sizes or number of servings that are listed in the container. I think oftentimes people might eat an entire container of food and not really realize that calorie amount listed was only for half or part of that container. And then lastly, on the left arrow, the new label does have amounts of calcium and vitamin D. So we'll talk about a little bit later why those are important. Okay, and then just kind of quickly, I really love this tool, the stoplight. It can be really helpful for kids and adults. And so just to kind of quickly walk through the green or the go foods we've kind of already talked about. Those are going to be your foods that you really want to have all the time, have at every meal. Then we move down to our yellow, our slow foods. Those are going to be a little bit more in moderation in the diet. And then lastly, red or woe foods. Those are going to be your highly processed foods that really should be reserved for special occasions. And then, again, they can be a part of the diet. We can have some woe foods part of an overall healthy diet. We just might want to limit them and not have them every day. And so, going, back again to taking the unhealthy beverages out of the home, a big first step I often talk about with families is really removing those woe foods out of the home so that we can eliminate any excess or daily consumptions. And then another thing I talk about often with families is definitely the difficulty of eating on the go, eating healthy on the go. Schedules are hectic, kids' schedules are hectic. And so the key definitely is planning. I have a few snack ideas listed that you can have easily accessible in the pantry or the fridge just to kind of grab and go on your way out of the house, or maybe even as a quick breakfast. If we're skipping breakfast, these might be a good idea. And then I really do like to think, back on that my plate when we're making healthy snacks. So trying to incorporate a grain and a protein with a fruit and a vegetable. And then meal prep, I know, is definitely a hot topic these days. And I love to emphasize that it really can be as simple as just making a batch of veggies for quick snacks, again, at the top, or, adding them to dinners throughout the week, or even just making a batch of brown rice or quinoa, chicken, just to use, again, throughout the week in dinners and lunches. And then, of course, if we didn't have the chance to plan, there's always still hope. As we know, a lot of fast food chains and restaurants do offer healthier and lighter options. So, if we are having to go to eat out, trying to look more often at those, leaner meats, again, the grilled chickens, trying to replace fries with a side of fruit or veggie, skipping the soda, trying to do more, water, milk. They have those usually available now. And then lastly, I did want to talk on just kind of making overall healthy lifestyle changes. It can be difficult. So hopefully some of these points kind of help walk through how to be really thoughtful about the process and really, set yourself up for success. And so these are kind of some of the things that I'll usually walk through with families in clinic, trying to look at what are those areas that, we struggle with. Are we eating out a lot? And then jumping down and looking, what are those barriers? What are the kind of the causes of some of those struggles? And then how can we plan? If we're have this goal of taking all the junk food out of the house, what's going to be our, source of snack, if that's kind of what we're snacking on right now. Do we have other snacks? Do we need to find other snacks? And then definitely for goal setting, attainable is definitely key. We don't want to set these large, lofty goals. Sometimes even just one goal is enough to start with. And then of course, writing down your goals too, to make those a little bit more concrete. You can post on the fridge for everyone to see and make sure the whole family's on the same page. And then, of course, lastly, important to reflect and look back on, were we successful? Maybe going back at that second point, and recognizing were there new barriers that came up. And of course, no one is perfect. And so it's definitely more valuable to try again and use mistakes as an opportunity to make the kind of your next attempt a little bit more successful. And then kind of next, I just wanted to talk on some of the common nutrition topics we might see in neuromuscular diseases. We might have some excessive weight gain related to medications or decreased lower energy needs. One thing I really do like to note that, weight maintenance might be preferred depending on your child's weight status or age. It may be more appropriate for them to maintain their weight and grow into their weight. If weight loss is desired, we definitely want to be really careful about how we approach weight loss for someone with a neuromuscular disease. Anyone who has tried to lose weight probably knows that often comes from muscle loss, not fat loss. Definitely a natural response from the body is to hold on to those fat stores. And so it really is important to work with your whole healthcare team to really make sure that we're maintaining as much muscle as possible through eating healthy and physical therapy. And then, of course, we never want to single out a child. Any healthy, changes that we're making are going to be for the whole family. And so, kind of thinking back on that last slide about, what are some of those healthy changes that we can make as a family. And then, lastly, I really do like to emphasize that if there is a problem with overweight, it's never about the way a child looks or the burden they might place on caregivers. It is always about ensuring that their bodies are as healthy as possible and keeping them as functional and independent as they're able to be. And then to kind of switch onto the other hand, we do have some kiddos that struggle with gaining adequate weight, whether that's related to maybe higher energy needs or feeding difficulties. And so some things I often talk about are what I call calorie punching. So adding some of those additives you might see in the middle bullet just to give extra calories to every bite. And then power bites. So once we're full at a meal, maybe taking 2 or 3 extra bites just to kind of maybe stretch our stomach just a little bit more. And then if we have maybe issues with early satiety, we might have to do more frequent meals and snacks. And so trying to eat every 3-4 hours. And then, there are options for nutrition supplements can also be really helpful for getting in those extra calories. So having a Pediasure with a meal. DuoCal is a neat powder that you can actually add to some foods and beverages. And of course, some of these nutrition supplements are covered by insurance plans. So you can always talk about that with your provider. And then of course, we really want to focus that here again. We're talking about, focus on health and functionality, keeping our bodies as healthy and strong as possible. Some other things that we might see are swallowing or dysphagia, feeding difficulties. And so some of those warning signs you'll see listed right there, you know, coughing, choking. Obviously, a lot of providers probably are asking these questions. And so we really want to pay close attention to these. And then, you know, if there are these concerns, that's when we might need to talk about with the team about if a swallow study is needed. And then, you know, after a swallow study, there might be a speech therapist or an occupational therapist that can provide any kind of recommendations or modifications if it is severe. And then next, just to kind of talk briefly about G-tubes. I think a lot of families do have a misunderstanding that, you know, G-tube might mean that their kiddo can no longer eat by mouth, which is definitely not the case. We can use them as little or as much as we need, you know, maybe just for fluid and medications, or we can use it for 100%, you know, sole source nutrition. And formulas are definitely really advancing and exciting these days. We have a lot more food-based commercial formulas, which kind of mimic more of like a regular diet, and then all the way down to, you know, your amino acid formulas, which are going to be your highly broken down formulas. You know, some kiddos that might have delayed emptying or just overall GI issues might benefit from an amino acid formula, but I really did want to note that I've got kids, you know, in our clinic with all diagnoses that are on the whole range of all of these formulas. So again, just focusing, every child is unique and we really want to individualize every regimen. And then just to talk about constipation, it can be pretty much multifactorial, whether it's poor fluid intake, poor gut motility, low mobility. And so these are some of just kind of dietary interventions that are a little bit more preventative. Of course, if we're having a more severe instance of constipation, we might need a little bit more of a medical intervention, but, you know, prevention is definitely key. And so, you know, just a few tips of, you know, putting a Camelback on the back of a wheelchair that has a little straw that comes around, or bringing a water bottle to school. Fruit or apple juice definitely can be helpful for some of my kiddos with G-tubes. And then I definitely do have families too that do these abdominal massages that can really work for constipation. And of course, activity. Brittany can talk a little bit about that. And then definitely unique. I'm not sure if many families realize, you know, is your child comfortable in the bathroom and on the toilet? Are we kind of moving from side to side, trying to balance on the toilet? And there are adaptive toilet options. And so that might even be really helpful in terms of constipation. If we're, you know, using our muscles in our upper body to keep us on the toilet, then we're not using the right muscles to go to the bathroom. And then ultimately, obviously, if none of these interventions are working, you know, medications really might be needed. And definitely, we definitely see that a lot with our neuromuscular kiddos. And then lastly, just to talk about vitamins. Obviously, the best source of vitamins are going to come from your foods. So making sure we have an overall balanced diet in fruits and vegetables, whole grains, proteins. Those are all going to provide all of the micronutrients and vitamins that your child needs. But definitely, if we're not the best fruit or vegetable eater, we're not getting a really balanced diet, multivitamins can kind of help and fill those gaps. And then, of course, important with our neuromuscular population would be calcium and vitamin D for bone health. Kiddos that might be at risk for vitamin D deficiency would be if they're non-weight bearing, on steroid medication, maybe they're not getting enough in their diet. And so calcium and vitamin D really do work together. And so making sure that we're getting 2-3 good servings of high calcium foods daily. So obviously your dairy proteins are going to have your highest sources of calcium. Fruits and vegetables, there are some other foods that do have calcium. You just might have to get a little bit more to meet those needs. And certainly if we're not meeting calcium needs in those 2 to 3 servings, that's when we might need to start a supplement. And then of course, vitamin D would be indicated if we have a deficiency, or if you're followed by maybe an endocrinologist that might recommend vitamin D as well. And so that is it for me. I did include my email address. I know some MDA care centers don't have a dietitian, and so I did want to provide that just as a resource for families here on the presentation today. I might not be able to answer all questions, just not as part of the full care team, but I would be happy just to address any general questions that we might not get to in the Q&A at the end.
Okay. Hi, I'm Brittany, and I'm going to be talking about some of those physical therapy implications in muscular dystrophies, and then kind of just to go off of what some of the things Grace mentioned in her presentation. So some of my objectives are going to be to identify specific muscles for strengthening and stretching, classify interventions to improve range of motion, because that is something that's really important in this population. Understand the purpose and effective use of equipment. Equipment management is also a big part. Becoming familiar with additional treatment interventions in conjunction with skilled physical therapy services, and then also understanding the benefits of those skilled treatment sessions. All right, and go to the next slide. Okay, so why PT? Why does PT play such a role in this population? So, and this is not a complete list by any means, but I just want to touch on some of the major things that PT does in order to help kids with this population. So one big thing is decreasing risk for contractures. And so I have a few slides coming up too, talking about, with that range of motion, because contractures are one of the major things that start to develop early and then can kind of get in the way of a lot of functional skills and things like that. So you definitely want to help address those early, and that's a lot of getting PT, and then also very important, parent education. The other thing we want to do is we want to enhance functional mobility. We want to preserve as much function as we can, and then also by giving adaptive equipment and things like that, enhance how much they can do, throughout lifespan. Improve posture, and so posture is something that definitely falls with the ambulatory and the non-ambulatory population. We work a lot on posture with like gait and standing, and then also very important, making sure wheelchairs and things like that, they have the proper alignment there. And so I'll talk about that more later as well. Reduce frequency of falls and injuries with the ambulatory population, and that also kind of goes with the contractures. As the muscles get really tight, it can increase their risk of falls when they're navigating their community and outdoors and things like that. Equipment management, which I'll talk more on later. And then also enhancing the effectiveness of medications. And this isn't something that has been researched. I know there are the beginnings of research for a lot of these things, but with the medications like Exondys, Zolgensma, Spinraza, all of those kinds of things, from a PT standpoint and from patients that I've talked to in the past, as they start those, sometimes they will, gain another skill or whatnot, and so that they didn't previously have. And so from a PT standpoint, I think that it's something that we can continue to address with them to help them learn this new functional skill that they now have. Improving breathing mechanics, definitely important. With some of those muscles that get tight, the breathing pattern changes, and so I'll talk more about that too. And so we want to make sure that they have the most appropriate and effective breathing mechanics. And so then also improving and maintaining function post-spinal surgery. Development of scoliosis is very common. And so that can limit functional mobility significantly, especially right after the spinal surgery. So PT can definitely help with that. Assessing for skin integrity, looking for pressure ulcers, things like that, just depending on, and that kind of just puts everything together, going with posture, going with tightness, things like that. You want to make sure when they're laying down, when they're seated in their wheelchair, things like that, there aren't any excessive pressure points anywhere. And then also assisting with reducing obesity and improving overall cardiovascular health, which is general PT thing. And then also rehabilitation after injuries, because as physical therapy, someone coming in with a ankle sprain, with a neuromuscular disorder and without, the rehabilitation can be a lot different. Okay, and next. Okay, so I just touched on some of the functional limitations that we kind of addressed. And so I separated it by ambulatory and non-ambulatory. So ambulatory, the big thing is gait, looking at those compensations, which some of the compensations are functional, and it helps them, with walking faster and things like that. But we do want to make it safe and reduce the risk of further injuries. Working on stairs, if you have stairs at home, at a limited aspect where you're not fatiguing them. But if it's for functional mobility, they need to get to their room, to the bathroom, whatnot. So that's something we can work on. Working on floor to stand versus if it's using, you know, an external device and things like that, another very functional skill. And then also balance on level surfaces is a common functional limitation. And then for the non-ambulatory population, one of the functional limitations is just, you know, general ADLs, you know, self-care, hygiene, brushing teeth, that kind of thing. Transfers from wheelchair to bed, toilet transfers, things like that. Postural alignment, definitely. And as they grow too, because kids seem to grow very quickly, making sure that we make the right adjustments for them as they grow. Pressure relief is one of the things as well, just depending on what kind of device that they have for that. And then also impaired breathing mechanics, and that also comes a lot from those postural deficits. Okay, so this is just a general slide. I'm not going to talk about every single muscle, but this is just kind of more for reference because I'm going to go into more of the muscles that are commonly affected. And so this is just kind of a reference slide to go back to so we can look at that. And then the following slide is also, and I'm not going to go too in depth, but this just kind of highlights different types of muscular dystrophies. And so where it's yellow, it kind of shows the muscle types affected. And so this is just generally for me to show that there are different muscles that can be affected. So your treatment plan is going to be different based on what you see, and it's not all encompassing. Okay. So just to talk a little bit about muscles. So the muscles that typically get weak in general are the hip extensors. And so those are the muscles, the glute muscles, so which could make it difficult for things like transfers, getting in and out of a chair and that kind of thing. The hip adductors, which are the inner thigh muscles. And so a lot of that comes from when they're in the wheelchair, a lot of times their legs will be in a wide base. And so those inner thigh muscles get weak because they're so stretched out. The quadriceps, you know, the muscles right on top of the knee, which are also, you know, standing, doing that sit to stand transfer, things like that. The abdominals, definitely a lot of the postural deficits come from having increased extension in the spine, and then the pelvis tilts forward. And so then that stretches out the abdominals. It makes it harder to engage. Deep neck flexors, are also affected. So then you'll see kind of a more forward head posturing. Shoulder depression and retractors. And so there are muscles in the back that kind of hold the shoulder blade in place. The shoulder flexors and abductors, so that's bringing up shoulders in the front and then also to the side. And then also the triceps on the back of the upper arm. So those are just general muscles that are typically, that we see are typically weak. And so on the opposite side, pretty much exactly, are the muscles that typically get tight. And so these muscles are typically get tight because they are the ones that we use a lot. And so it's kind of the muscles that they use to stabilize. So the hip flexors, you know, like doing a knee to chest, that those muscles get tight. And then those also can get tight from a lot of sitting. And then hip abductors, which are opposite the inner thigh muscles, just because of that wide base positioning, and then also in standing with the wide base. The hamstrings, back of the leg, which is a typical muscle that is tight for everybody. The calf muscles, where you see a lot of that toe walking and things like that. The back extensors, so that's a big area to stabilize. Cervical extensors, which are the muscles in the back of the neck, is also a stabilization muscle. The front of the chest, and that kind of goes with that forward shoulder posturing. The lats, which are on the side of the trunk, those muscles get tight as well, also for stabilization. And then also the biceps. Okay, and we'll go to the next slide. Okay, so I'm just going to touch on the next few slides a little bit about range of motion, because I do think that it's something that needs to be addressed early in these populations, because it is something that as they start to grow, muscles do typically get tighter in anyone. And so you want to make sure that you're addressing it early, even if they're not super, super tight at the beginning. So for the next few slides, I'll just talk about all these things on here. So we can go ahead and go to the next one. So the first thing is night splints, and night splints are very commonly prescribed. So they help maintain the ankle range of motion. So for that tight calf muscle, kind of keeps it in a good position. And so just kind of keeping that range of motion as they continue to be ambulatory can help reduce risk of falls, because when their calf muscles are really tight, their foot points down like this. And so if you think about when you're going to step over an obstacle, things like that, you have to either lift your leg really high, which they typically do, in order to clear your foot so the toe doesn't drag on the ground. So night splints are good as opposed to doing something like a daytime AFO, which I know is sometimes prescribed for them. And so it's very patient dependent. But night splints, you know, don't have to worry about them falling because of the weight of the daytime AFO or whatnot. From my experience, most kids do not tolerate these at all. It's very rare I get someone who tells me they wear them every night and it's okay. So something I'll tell parents too is just trying to wear just one on each ankle each night, and then trying to switch it out that way to see. But you know, anything is better than nothing. So. Okay, next slide. So definitely passive stretching. That's just kind of one of those basic things to increase range of motion. And so I put pictures of just some of my favorite exercises I typically give for the calves, which is that first picture, bringing the toes up, and then the hamstrings, the picture with her foot on her shoulder. And then the hip abductors is that bottom left one where he's kind of holding his leg off to the side. That one I probably don't do as often just because for safety, because you kind of do have to do it off the edge, but it's a tight muscle, so you know it's an option. And then for the spine too, I didn't put hip flexors, but that black and white picture is for the hip flexors. And then for the spine too, I'll do a lot of stretching because they do stabilize by extending their spine a lot with walking. And so I'll kind of give those kinds of stretches too. And we've had some positive things from that. So, okay, next. So resting hand splints, so that's more, occupational therapy works more with this than I typically will address, but you know, we do work a lot in order to get the best equipment, so it kind of can preserve that wrist and finger range of motion, and that's more, you know, keeping their functional skills and, you know, all those ADLs and that kind of thing, without reducing risk of finger contractures or wrist. Okay, and so for the stander, one of them pictures are hiding. So for the stander, so there are definitely benefits for the stander. So it can improve postural alignment and spinal elongation. And then by default, you already get a stretch on the calves with that weight bearing, and then you also get a stretch of the front of the trunk for those hip flexors. So it can improve tolerance to weight bearing. Improve digestion. So as Grace talked about, you know, with constipation and things like that, a lot of that will stem from their posture. And so by putting them in a stander, that can kind of help, you know, get everything into an alignment. And a lot of times they'll be in the stander for 15 to 30 minutes a day, just depending on how much they tolerate it. And then it can also reduce the risk for contractures. So in here, these are just kind of different options. Most commonly, I see the top one, which is just the power wheelchair, and so it has a standing feature, and then they are able to navigate it with their joystick, so that kind of enhances some of that functional independence. But then there's also the mobile stander, where they're able to use the wheels to propel, and then just a regular supine stander, which is probably the least functional. I say that, but then you can also add trays and stuff like that to do more fine motor stuff on there. Okay. And then just general positioning, being on their belly gets more stretch of those hip flexors in front. And then seated position, want to make sure we don't have any of that C positioning, kind of how that blue man on the picture is kind of showing, trying to get that. And the wheelchair will help a lot with that, as far as like if we need a different seating system, if we need different trunk supports, things like that. And then also on the back and the side, for sleeping positions, making sure on those bony prominences, we put pillows on there so we don't get any pressure ulcers. And then also putting the pillow under the knee sometimes can help reduce the stress of the low back. Okay, next. Serial casting, not my favorite recommendation, personally, just because it's not for severe tightness. And a lot of times with these kids, they do get severely tight, and then it does limit their functional mobility a little bit when they're, if they're walking or whatnot because of the weight of the cast. But it definitely is an option for if they have that minimal tightness. Okay, next. Okay, and so then for strengthening, so the big thing, the big common thing is just not overexerting them when they're exercising. So we don't want to just completely not exercise at all for fear of breaking down the muscles, but we also don't want to overexert. So we want to find the balance in between of that. So a lot of times I'll recommend little to no resistance. Body weight's usually good. And then aquatic therapy, I do have a slide on that. That's a really good option for these kids. And then also working on wheelchair mobility is a good strengthening activity. Okay, so aquatic therapy, I could do a separate presentation really on aquatic therapy, but I'll just touch on some of the basics. With aquatic therapy, the properties of the water can help reduce the stress on the joints. Then the temperature, usually they keep it around 98 to 99 degrees. So it can provide relaxation benefits, help relax the muscles. It can enhance some respiratory exercises. And then also there's a good social interaction portion of that. I know at TCH with our aquatic therapy, pre-pandemic, there are multiple people in the pool so they can see other kids and that kind of thing. And then you can also do some of the exercises you do on land, also in the water. Okay, and next. So these are just some exercises I'll recommend for the ambulatory population. Just touched on some basic ones. So breathing mechanics, so you'll see them on both slides for the ambulatory and the non-ambulatory population as well, because that's something we want to work on, doing diaphragmatic breathing, reducing a lot of chest breathing and raising up your shoulders. And then we also work on some of the balance things and negotiation of obstacles, just for functional mobility, working on sit to stands. Wall squat is something I'll do a lot. A lot of times I've run across with Beckers and things like that, with a lot of kids once they reach their teenage years and they want to go to the gym, they want to lift weights. So I try to work on their mechanics with that and just show them, exercises that seem simple, but also help them address what they would like. And then their bottom right picture is just showing exercise to help strengthen the back muscles. And then also I'll do a lot of things in half kneel and tall kneel. All right, and next. Okay, and so these are some exercises I'll do a lot for the non-ambulatory population. So again, with the breathing exercises, I like to do a lot of glute sets, just kind of squeezing the glute muscles together, just to kind of preserve some of that muscle strength for transfers. Ball squeezes for those inner thigh muscles. Working on bringing the shoulder blades down, which is an easy one to do just on the wheelchair, on the handles, doing chin tucks to reduce some of that forward head posturing, and then also pressure relief as well, which if there's a tilt in space with the powered wheelchair, that helps a lot too with that. Okay, next. Okay, and this is just some equipment, power manual wheelchair, using a sliding board to help with transfers. Definitely want to look into getting a shower or bath chair, Hoyer lift, and then the bottom ones are kind of more OT, but more functional things like using a reacher, and then a long handle shoehorn so that they can take their shoes on and off, that kind of thing. Using a sock aid, and then also using a long handle sponge. So these last four I don't typically address as much, but we do have an equipment clinic at Texas Children's too, and we work a lot with OTs in order to help with those kinds of things. Okay, so basically, so my take-home message was just one thing I like to tell parents too is just treating the functional impairments versus the diagnosis. I've never met, two patients that were alike, even if they had the same diagnosis. So it's just kind of looking at that, and in regards to looking at equipment needs, that kind of thing. And then we also want to maintain the functional strength and the range of motion without overexertion of the muscles, and then addressing equipment needs early in order to reduce delays. All right, and so that is all we have. And so these are just a couple, I didn't directly quote a lot of these, but I wanted to see what recent research they kind of had, which there's really not a ton. So definitely more needs to be done on that, especially with all of these new FDA medications that are kind of coming out. All right, and so we'll open the floor for questions.
Thank you, Brittany and Grace. Grace, we had a question come in. Do you have a recommendation for a good multivitamin?
So chewables will be the best because chewables are going to be a complete multivitamin if we're really trying to get a complete multivitamin.
Mm-hmm.
So Flintstones is one that's really common, available at all grocery stores and pharmacies. And that one, look for the one that says, I think, Flintstones complete, because then marketing is kind of key with vitamins. They can say, it'll say like Flintstones with iron, and it really only has iron. So look for the complete one, and it'll have everything. And gummies, just caution those with the sugar that's added to gummies, and often you can't really get iron and calcium in a gummy, those minerals. So again, the chewable.
Got it. And I was asked to show the slide on equipment, so let me go back for a minute. Brittany, you might need to
Forward. Sorry. And yes, right there. That's it. Yes.
Okay. So is there a question regarding this? Dr. Did you have a question? Okay. If he's got a question, he'll type it in.
Okay.
I wanted to ask Brittany, could you just highlight on the insurance benefits of Medicare and Medicaid when it comes to wheelchairs? I know a lot of folks have some confusion when they say, their wheelchair would be covered and then they have to go get a power chair and then the power chair isn't covered. Can you just highlight some of those important facts for our audience?
Yes, so that is definitely a big thing. So my understanding with Medicaid is that they only will pay for a chair every 5 years. So a lot of times it is difficult to get both. And so it's difficult to get both a power chair and a manual chair, and then also with the stander and gait trainer. That's usually the two issues that we'll run into, is getting both of those. So a lot of times it's a lot of appeal process with that, because there are benefits to having both a manual and a power wheelchair, just in case of, power chair failure and those kinds of things. But most of the times I think that the therapist can write really good appeal letters if they do receive that, because I haven't gotten a whole lot of people that tell me that they weren't able to get it. So most of the times I think it comes through. I think it just takes a little bit more work.
Okay. And Grace, is there any way, does insurance cover feeding tube supplements?
Yes, it depends on the insurance. Sometimes private insurance, they'll cover the supplies but not the formula, so that's sometimes fun. But kiddos with Medicaid, it's usually pretty easy, at least in Texas. I can speak only really to Texas, but yes, insurance will cover tube feedings and even those oral nutrition supplements. It just depends on the particular insurance plan. But I usually, even with private insurance, haven't had too much of an issue with my kiddos getting oral supplements, just with the right medical justification.
Okay. And then could you just clarify, Grace, what you meant about not getting calcium in gummies? Did you mean it's not absorbed because
Oh, yeah. No, I just meant that it's a mineral. So just in like making the gummy, it's not really fun to put calcium. I don't know. That's kind of the way I thought about it.
Okay.
But they do have, there are calcium gummies. I wonder sometimes supplements are hard just because they aren't regulated by the FDA. And so you really have to kind of look for a reputable brand and make sure that, because they can say anything is in there.
Sure. And then, Brittany, as far as non-ambulatory and exercise, how, and Grace, this would probably be a twofold for both of you, but, how do you, exercise and try to maintain your weight when you are in a chair?
Right. And a lot of that I think comes from, using the standing feature on the power chair, which typically is an added feature in getting that standing and getting that weight bearing. Because I think that, and I'm sure Grace can really touch on, alignment and digestion, but, getting them in the appropriate alignment and things like that can help with that digestion. And depending on what food they have coming in, I think can kind of help with that as well.
Okay.
Yes, and then of course just eating as healthy as possible, obviously.
Sure. Sure.
Really limit again those low foods, and you can still have them, but of course just trying to eat.
I like the stoplight. I could use that for my child.
Yes, yeah, and so
I like the visual.
So yeah, and then of course really I definitely try in clinic just to work with kiddos when they're young.
Mm-hmm.
We really want to make those healthy habits at an early age, and so we're not having interventions when on a 16-year-old. It's a little harder to bring a message home.
Sure.
But yeah, sometimes it can be difficult for kiddos that might be on steroid medications, and they might be a little unavoidable, but of course we can always work with the neurologist and see if there's any medication changes, and then eating as healthy as possible.
It's a team approach when it comes to something like that.
Definitely.
Well, I am not seeing anything else pop up. I want to thank you both for your time today and taking part of your Saturday to talk with us. So thank you very much.
Thanks.
Hey, thank you.
And this will conclude our seminar for today. I want to thank all of our presenters for their time and effort they spent in putting together all their presentations. I also would like to once again thank our seminar supporters, Biogen, Numotion Foundation, and Genentech. And thank you to everyone at home who watched on their Saturday to partake in this. And I hope that you found this information beneficial. We have recorded this, and it will be on mda.org in a few weeks for viewing. And please note, if you have questions about what you saw today, please email at mdaengage@mdausa.org. And finally, I want to remind everyone that I will be sending out that brief survey. So if you could please fill that out, I would appreciate that. And thank you all again for joining. And please join us for our future Engage events. So have a great rest of your day. Bye-bye.